Good afternoon, Dr. Blacklow.
Good afternoon.
To start off, could you tell me where you went to medical school?
Yes, I went to Columbia University College of Physicians and Surgeons,
Okay. When did you graduate?
1963.
And when did you start practicing?
I started my residency in 1965, and then most of my career has been in an academic setting. I've done some practice within an academic setting, and after a stint at the National Institutes of Health involved in research, I would say you'd consider my practice activities beginning in around 1971.
Okay. And what did you choose as your specialty?
Infectious diseases, and within that, research in virology. But most of my clinical activities have been within infectious diseases and also in the general field of internal medicine, which infectious diseases is a part of.
Yes. What made you choose infectious disease internal medicine as a specialty?
Hard to answer, but I do think that I was always very fascinated by the very rapid and impressive advances that were made with the development of vaccines to prevent infectious diseases, as well as with the development of antimicrobial agents, antibiotics.
Yeah.
And then following that, during the period of my career, antiviral agents have come along. And what impressed me about infectious diseases as a field of clinical and research activity is that they're readily amenable to prevention and cure. And that was a great appeal to me. So that led me into this field.
Could you describe a typical day when you first started practicing?
Well, my typical day really was a complex one. It wasn't strictly practice. It was involved in education, in research, and in practice. The practice was predominantly consultations with inpatients, hospitalized patients who had infectious diseases. And infectious diseases in hospitalized patients, not just exotic diseases for people who travel, things like that. We do see some of that, but are predominantly infections that take place as a result of complications of surgery or chemotherapy or other things that happen to patients as part of other disease entities. So a typical day for me really was a day running back and forth between a laboratory, into the hospital, into the classroom for medical students. And it was a very, very enjoyable experience for me.
How has your typical day changed over the years? Has it?
Well, for me, it changed a great deal because we're talking now at the University of Massachusetts Medical School, and I came here in 1976, just at the time the University Hospital opened here in Worcester. And my activities were to, when I was recruited here, were to develop a comprehensive program in infectious diseases, academic, research, clinical care, and I did that for about 13, 14 years. But after doing that for 13, 14 years, they sort of booted me upstairs and had me become chairman of medicine. So I did that for a decade, the decade of the 90s. And I stepped down from that at the end of the 90s. My activities during the period of the 24 years or so that I was here full-time changed a great deal, therefore. And in the times that I was head of infectious diseases, it continued as this, as I described earlier, as this complex of research and education and clinical programs in infectious diseases. But when I became chairman of medicine, that changed enormously. And then that we related to lots of the changes in medicine that we see today, because heading up a medicine department involves obviously much more than infectious diseases. It involves house staff, it involves many practicing physicians, it involves researchers, it involves education of medical students, house officers. It's a very major program. And as well, as you know, the University of Massachusetts Medical School and its hospital changed many of its structures during the period of 1990s when I was chairman of medicine. And included in those changes were a merger with Memorial Hospital in Worcester, so that now we have UMass Memorial Health Care, which is the key clinical partner of the medical school. And my activities were heavily involved in that merger as well. So I became more of a administrator, healer, honorary psychiatrist to many people, at the same time trying to continue active in an academic vein. My practice activities diminished during this period of time because there were only so many hours in a day to get things done. But so it's a long answer to your question, but they have changed a great deal and because of the unique experiences I've had in my career.
So what are the hours of your typical day like? Have they changed over the years?
Well, I guess they started long and they continue long. Now at this time I'm semi-retired. Okay. So you wouldn't want to compare my hours now, although I probably spend half a week editing a couple of journals and a textbook of infectious diseases and involved in education and so on, but very different from the other 24 years that I was here full time. But they were long hours. It's hard to quantitate them, but up early, home late, and involved in a lot of usually stimulating activities. But when one gets heavy into administration, the activities are stimulating, but sometimes they can be frustrating, and you have to learn to deal with those. And I think I learned that in the period of time that I was heavily involved in administration.
When you did practice medicine, did you ever make a house call?
I didn't. Okay. Never was involved in any house calls at all. I would say, though, that I certainly had experience with house calls because my father was a general practitioner.
Oh, okay.
He lived in Massachusetts, eastern Massachusetts, a town called Belmont, as outside of Boston. And he practiced medicine for 62 years. And during that entire time, until 6 months prior to his death, he made house calls. And as a child, I would go with him on those house calls and saw this kind of role model, and indeed that had, I have no question, had an impact on my initially deciding to go into medicine. And my decision to go into medicine, by the way, was to practice medicine. But that changed when I got into my residency and during medical school, and I saw other aspects of medicine that I was interested in, particularly the clinical research aspects involving infectious diseases. So, you know, for me, those changes probably occurred during medical school when I had the opportunity to do some part-time laboratory research, and then following medical school had an opportunity to, and following my first years of residency, had an opportunity to go to the National Institutes of Health in research in Bethesda, Maryland, and that led me in a direction and schooled me in understanding the importance of medical research that can have an application for clinical care.
Did you use the telephone to talk with patients?
Yes, somewhat, but I would say fairly limited, fairly limited.
Okay.
We didn't have an email.
I think you already described somewhat about your rounds at the hospital. Is there anything you'd like to add?
Well, I think most of my rounding was involved with medical students and house officers dealing with problems of patients with infectious diseases. And those rounds would take probably about 3 hours every day, I would say. Typically in the afternoon. You know, there might be some days it would be an hour and a half, and other days it would be 5 hours. It really would depend on numbers of patients to be seen, the complexity of their problems. They would involve seeing the patient, examining the patient, discussing the patient's problem with them, which I have always felt is the most important ingredient in building a doctor-patient relationship is openness with the patient. And then going with residents and house staff to a clinical microbiology laboratory, looking at appropriate specimens that might be relevant to that particular, came from that patient, and that would be relevant to their diagnosis, going to the radiology department, looking at appropriate x-rays that may be relevant to that, could be relevant to that patient's care, and then discussing and teaching with the residents and house staff. So it was seeing patients, taking care of their problems, but in the context of a lot of education that was going on. And this kind of activity continues today, obviously, but is somewhat more under pressure of time than it was certainly 20 years ago. Time that is really economically driven. And perhaps we'll get into those discussions later in terms of how the economics of healthcare and academic healthcare have changed.
Generally, who were the patients that you saw? I guess age, like location, where they were.
Right. Yeah, patients with infectious diseases know no age boundaries, and although I did not have a residency in pediatrics, I did do some pediatric infectious diseases, and I would see patients who were as young as newborns up all the way up to the elderly. Because the management of infectious diseases, certainly even in the pediatric age group, is very similar to that in the adult age group. There are differences, but for the most part, they're very similar. All that being said, you know, probably 95% of the patients I saw were over the age of 18, and they presented with all the complexities of problems ranging from malaria to pneumonias, garden variety pneumonias.
And most of them came from the Worcester area?
Most would come from, most reflected the demographics of patients hospitalized at UMass Memorial Healthcare. Even though when I was clinically active here, these two institutions, Memorial and UMass, were not clinically merged, I still was involved and on the staff at Memorial and saw numbers of patients there as well. Because within infectious diseases, the area that I set up here, beginning in 1976, we integrated the activities between Memorial and UMass from the very beginning, so that people, faculty who were involved in clinical infectious diseases at UMass Hospital did service for several months a year at Memorial Hospital and vice versa, so that we saw the demographics of patients who were hospitalized at both hospitals, and which really serve not only just Worcester, but the surrounding region, you know, going 20, 30 miles around Worcester, and occasionally some who were referred in by helicopter in later years from around the state.
Did patients have the opportunity to choose their physician?
Early on, they had a greater opportunity to choose their primary care physician than in later years, when they still have considerable opportunity, but it can be somewhat limited by the kind of health insurance they have. That being said, as you probably know and have heard from others, most of the full-time, anyway, physicians at UMass Memorial Healthcare are accredited with many HMOs and other healthcare providers in the area, so that that, for the most part, is not an issue.
How many patients of yours were in the hospital at any one time?
Well, again, patients that I were involved with, I was seeing usually in the role of a consultant. So I was not the primary care physician. On occasion I would be, but it certainly would not be large numbers as a primary care physician.
So how do you think your being a physician affected your family?
I would anticipate in a positive way. I think they, as they grew up, they realized that one was in a profession that was to serve others, was to develop information to try to prevent disease and to try to treat disease and cure it. There was no question that a physician, clinically active physician or an academic physician who is involved in partial clinical care but many other activities, spends a lot of hours at work and is not easily available at home at beck and call. And that's the case for virtually all physicians and academic physicians, and I know you know that. But at the same time, I think most families understand that, and it's important for a physician, regardless of the role he or she is in, to try to make time for family. And although I think probably in the first half of my career, I probably was at home less than perhaps I should have been, I made intensive efforts. In the latter half, I would say, became more aware of it and tried to be more available. One's not at home as much as a banker or a car salesman. We understand that. And I think medical families tend to understand that.
Okay. Did you get any vacations?
Well, when I was a resident, we got a week vacation. We worked, interestingly, for my first 18 months of residency, I worked every other night, every other weekend, which is sort of a barbaric type schedule. Fortunately, they're not that severe anymore, and that's a good change. But in early years, there would be maybe a week vacation a year. I would say I'd take perhaps a couple of weeks vacation a year for probably the first 15, 20 years of my career, and then probably closer to 3 or 4 weeks in the latter 20 years of my career. That would be my sense of vacation. Well, we took time off. It wasn't an enormous amount of time, but there was time off, and it was appreciated.
So you don't think that having a father who was a doctor affected your decision to go into medicine that much?
I think it affected it in a positive way, although I ended up in a very different pathway than my father did. But oh yeah, there's no question I think it affected it, because if my father had been something else, I wouldn't have necessarily been aware of what medicine had to offer. I have no question that it certainly drew medicine to my attention in a very vivid way. I did consider, early years in college, well, maybe I should go into, law school or something like that, and try to help people through that. But I didn't want to sit around reading all day long and underlining texts for my career and looking in law cases for the rest of my life, and I found that rather dry, so I chose not to do that.
So what made you choose medicine exactly? I'm sorry, you probably said it before. But
Yeah. The opportunity to help people and to prevent and cure disease, and particularly in the area of infectious diseases, that really was a great appeal for me.
Why did you choose to practice here in Worcester?
That's an interesting question. I was first in, as I mentioned earlier, in Bethesda, and then I was recruited to an academic medical center in Boston, and I spent a few years there. And I was approached to come here, Worcester. I didn't seek to come here, but I was approached when I was aware there was a medical school developing here, but didn't know much about it. And one day there was a phone call, would you like to take a look at this? And I said, okay, fine. I came out, and I was impressed by the potential. It's interesting, the first chancellor of the medical school here, once the hospital opened, actually the first chancellor was Dr. Suter, who set everything up. But once the hospital opened, he was no longer the chancellor, and the chancellor at that time was Roger Bulger at the time the hospital opened. And his background was in infectious diseases. And he contacted me and said, we need someone to really set up a program here. Would you be interested? And I said, well, I'll take a look, and he directed me to the then chairman of medicine, Roger Hickler. And one thing led to another, and eventually I came here.
Do you have a favorite memory from when you practiced?
Lots of favorite memories. No particular one, I'd say, but lots of... I can remember some people who were deathly ill, and some right decisions were made, and it's a very good feeling. It's a very good feeling. There isn't a physician who doesn't know of patients who didn't make it, and for whom, you always scratch your head and say, if we had done this or done that, would something else have happened? Would they have survived? And every physician knows that, and there were always some of those, but fortunately they were far, far fewer. So I don't have any one particular story.
Okay. Is there a least favorite memory that you'd like to share?
Not publicly.
Okay, that's fine. So what were the most typical illnesses that you dealt with when you started practicing medicine?
Garden variety, respiratory problems, pneumonias, intestinal problems, gastroenteritis, urinary tract infections, postoperative surgical infections. These were very common, and they still are very common. We didn't have nearly as many problems with what we call infections in immunocompromised patients, patients whose immune systems are impaired, usually by what we as physicians do to them deliberately to try to make them better. Patients, for example, with cancer, or patients with so-called autoimmune diseases, where their body reacts against itself and produces diseases like lupus or rheumatoid arthritis. In any event, many of these patients undergo treatment which lowers their immune system, and as a result of that, infections develop. And that's an understood risk of therapy. We see many more of those problems today. Patients after transplantations, kidney transplants, bone marrow transplants, liver transplants, heart transplants, and so on. That's much, much more common today than it was 30 years ago. AIDS, where it's nothing that we as physicians do to patients, but where it's an infectious disease and their immune systems are impaired. And that's had a marked change also on infectious diseases. So these are the changes in some of the types of patients that one sees with infectious diseases today compared to 30, 35 years ago. But we still see, of course, the pneumonias, gastroenteritis, urinary tract infections, postoperative surgical infections, but we also see these other problems much, much more frequently.
What was the greatest challenge for you to treat such disease?
One of the very difficult infections to treat is one of the heart valves of patients. It's called endocarditis. That's a very difficult infection to treat and in some patients, and requires a lot of experience and clinical judgment. That has been consistent over the years as a difficult infection to treat. Another one is meningitis, where the infection takes place on the lining of the brain, and that can be complicated as well to treat. So these are some of the more complicated ones to treat, I would say.
What was one of the most important breakthroughs in disease treatment during the course of your career?
No question, the development of anti-infective agents. I think that's probably on everybody's list, regardless of the field of medicine they're in, as major developments of the second half of the 20th century. So the development of antibiotics like penicillins and cephalosporins and tetracyclines and immune glycosides and a whole host of anti-infective agents, and then the antiviral agents and the antiparasitic agents. And these were things that simply weren't there before the second half of the 20th century. I mentioned a disease just a couple of moments ago, endocarditis. Yeah. Endocarditis was a uniformly fatal disease, 100% fatal prior to antibiotics. It was like the most severe of all malignancies today, for which everybody would die from. Everybody died from endocarditis. Today, probably 85% or maybe even more of patients are cured with endocarditis with antibiotic therapy. So that certainly is a huge advance. And along with that is the prevention of disease with development of a multiplicity of vaccines, which we didn't have. Polio is always given, yes. Polio is always given as the great example, and it certainly is. And every time the National Institutes of Health is looking for money, more money from Congress, which is every year, they always trot that out as a prime example of what of basic research can lead to, and there's no question about that.
Describe the attitudes towards smoking and cancer throughout your career. Just a general attitude.
Yeah. Interesting. The public today is fully aware of the risks of smoking. That doesn't mean that people don't smoke, but it's, I mean, virtually everyone knows what the hazards of smoking are. That was much less so 35, 40 years ago. But when I went to medical school, we were taught by I remember one pathologist in particular who said over and over again that the overwhelming cause of lung cancer is smoking. And there is a huge risk to smoking. And at that time, the general public at large, and we're talking now in the early 1960s, the public at large, I think, really didn't have an extensive appreciation of the hazards of smoking. I think there was some sense that this wasn't a good thing to do, but I don't think they really had the real sense of what it really could do. Of course, smoking has more than just lung cancer as hazards to it, and we know that today. And that particular knowledge developed over the past 2 or 3 decades. So the risks that it poses for cardiovascular disease and other diseases. So there's been certainly a great growth in the understanding of the risk of smoking. But, you know, I may be a senior physician, but I'm not, I'm not that old. And we did know that 30, 40 years ago, we did know that there was a hazard to smoking. It just wasn't widespread public knowledge. There was some knowledge with the public, but it wasn't widespread and it wasn't extensively accepted. Yeah, you didn't have you didn't have anything on TV or like that. Of course, today you have it on TV, you have advertising, you have all that, and yet smoking continues, although less. But obviously there are very sophisticated attempts at marketing by the tobacco companies, which they like to camouflage in a variety of different ways. It's not a happy part of society.
In terms of technology, what is something that doctors take for granted now that you didn't have during your career?
Well, I'm sure every doctor you ask will say a lot of the radiological techniques that we have. CT scans, MRIs, everyone in the public, they use these terms. I often get a chuckle about professional athletes. They talk about, you know, I'm going to have an MRI done on my shoulder or a CAT scan done on my hand or whatever. And, you know, when I started my medical career, we didn't have any of this stuff. And there's no question, I think, that advances in radiological diagnostic techniques are the most impressive diagnostic technique changes that have taken place. They're the most visible. But there are other changes that have taken place as well. The ability to very rapidly diagnose a variety of blood test parameters. These can be done on an automated way today, very rapidly. And the same thing with diagnosis of a variety of infections can be done much more rapidly in many cases than was ever the case before. At the same time, it's amazing that there are some tests, the diagnosis remains as primitive today as it used to. And I think of an example being the stool guaiac for blood, for occult blood, for hidden blood in the stool. And that test really hasn't changed over the past 35, 40 years. And when I went to medical school, we did occult blood guaiac tests. In fact, as medical students, we would do it in place of the hospital laboratory. You can't do that anymore today. In a laboratory, all tests have to be done for medical legal reasons by a accredited hospital laboratory. We didn't have that years ago, and the medical students tested the stools because they were the lowest person on the totem pole, and they were testing the stools for blood. And today, that test is still the same.
Describe one significant invention that you've seen, and when did that start being used?
One that I'm sorry?
the most important one.
Oh, you want the most important invention? Okay. Well, that's a medical invention. I guess you'd have very many different approaches to that, to answer that question. And if you take a broad public health perspective, one might say the development of antiretroviral drugs, that is, drugs to treat AIDS. That's a very impressive development when you think of the fact that that is the epidemic of this lifetime for the world, and there are millions of people in Africa and around the world who are experiencing this problem, and there are drugs developed to at least control that to a significant degree, and for which delivery of drugs and payment for them is now the issue that's being faced and beginning to be dealt with. Now, that may not be the answer that you might have expected, but development of those kinds of drugs has been a great achievement for a major epidemic. And I like to take a public health perspective when I credit, let's say in quotes, major achievements that I've seen. And the development of vaccines to prevent many common childhood illnesses, those and adult illnesses, those are major achievements. And the development of vaccines to prevent major causes of pneumonia in the elderly, pneumococcal vaccines, development of vaccines to prevent chickenpox and mumps and rubella and measles and polio. These are major, major developments. So I take a public health perspective, if you will, if I'm asked the question, what is the major development that you've seen? I think that's what it is. I don't believe it's some major high-tech technique that's been developed to diagnose something new or to treat something new. Those are wonderful achievements, but I would not rank them at the level of the public health achievements.
Did you always have access to the new technology in your field?
Pretty much so. And I guess that's the advantage of being within an academic health center. So for the most part, yes. An area that I spent a number of years with was the discovering the viruses that cause very common diarrheal illnesses, and I was fortunate enough to be co-discoverer of one of the 4 major groups of viruses. And as part of that, 4 major groups of viruses that produce gastroenteritis, and as part of that, we've developed techniques, rapid techniques, to diagnose these in patients that are now used around the world. And so I find those things of great interest and of practical importance. And so it's sort of a first-hand experience I've had in that kind of thing.
What were some of the most important drugs that you used when you practiced medicine?
Well, we touched on this earlier, and they would be the antibiotics and the antivirals. Those are the important agents that I've dealt with. Now, there are obviously there are many other drugs that have come along dealing with gastrointestinal diseases, H2 blockers, cardiac diseases. There's a whole array of antihypertensive drugs, and these are very important agents that have come along. But from my perspective, in the practice and education and research I was involved with, certainly the anti-infective drugs are the most important ones from my perspective.
Did you always have access to the drugs you wanted to use?
Unfortunately, yes. There has been in recent years, on fairly rare occasions, some shortages of antibiotics, but fortunately they have not really impaired patient care. They become short for a period of time, but there are alternative drugs, and then the shortages are made up for. I do foresee potential problems with vaccines and availability of vaccines, and that could be a major problem for the next 20, 30 years. And we have a number of vaccines that are highly effective, and but for which there are only a few drug companies that are anymore making vaccines, and there's several reasons for this. One is that they are very concerned about liability issues and protection by the government against liability for side effects from vaccines. Any vaccine may have a side effect, even though it may only be in a small percentage of people. And it's a risk-benefit decision as to whether a vaccine should be licensed. Normally, the risk-benefit ratio is heavily on the side of benefit, and that's what gets vaccines licensed. Also, it is said by the drug companies that their profit in vaccines is very small. I'm not privy to that information. But the bottom line of this is that availability of vaccines may become a problem, in a very unfortunate problem for us in the years ahead, where we have vaccines that we know today are available to prevent lots of diseases, and yet we may find ourselves in the situation in the coming years that no drug company wants to make those vaccines. So the government, the U.S. government, needs to get more and more involved in figuring out ways to make sure we don't have to face those problems. Because it's really the government that has the ability to provide leadership, to have the mechanisms in place to avoid getting into these problems of shortages of vaccines.
How did patients without money get health care when you started practicing?
They simply got health care. They simply came, and I'm sure you've got that answer from other people that you've interviewed. They simply came to the hospital emergency room and were taken care of. I had my medical training at Beth Israel Hospital in Boston and Mass General Hospital in Boston. And I also did some clinical service at Boston City Hospital in Boston, which really was the major provider of indigent care in the city of Boston. And in medical school at Presbyterian Hospital in New York City. And also had some experience at Harlem Hospital in New York City and Bellevue Hospital in New York City. And in every instance, in every case, the indigent would simply show up in the emergency room and they were taken care of. There weren't any questions raised by administrators about how are we going to take care of this person, or this person should be taken care of through this mechanism, financial mechanism, put this person in an ambulance and send them over to that other healthcare institution. That never happened. That never was an issue.
Never an issue here in Worcester,
I never saw it as an issue here in Worcester in the years that I was here. I always found every patient was taken care of, and in early years, I did some limited activity at Worcester City Hospital when it still existed. It brings back memories. And of course Memorial and UMass Hospital, and would attend rounds at St. Vincent Hospital. So I knew all the major acute care hospitals pretty well here. And in my own personal experience, I always saw I never saw a patient, heard of a patient that simply wasn't given care. The indigent wasn't given care. It doesn't mean that today there aren't issues in how indigent get access to similar high levels of care as the non-indigent. And that certainly is an issue today, no question about it. Second, I think I should mention that there has been really very laudable programs of care for the indigent that have come out of the university hospital setting. People like Eric Garcia and others who have gone right into the areas of the city where the indigent need care, where there's a lot of AIDS, homeless problems, and I know that's going on today, and that's very laudable.
What were some fears and concerns about socialized medicine in the 50s and 60s?
Well, you may be surprised at the answer I'm going to give you, but I never had any concerns about it. And I don't view myself as a political zealot of any sort, you know, any far left winger or anything of that sort. I've always felt that that we have really in the U.S. lagged way behind in trusting the government to become involved as a primary provider of care. And that's, you know, there's been a paranoia in this country about permitting that to happen. And so what we've ended up with is a private enterprise system of health care, of a bunch of small, relatively smallish entities that provide health care with lots of middlemen operating in the healthcare system, and that's really relatively inefficient. We do have Medicare, yes, and most physicians will say that they find that Medicare is as efficient as any of the HMOs or private providers of health care. So that's supposed to be the evil government, Medicare.
So you're in favor of Medicare and Medicaid?
I am in favor, in some mechanism, of having a universal health care system. And how we go from the balkanized system we have today to that ultimate goal is sort of a minefield to walk through. One thing I know for sure, it needs straight talk from politicians, and that's difficult to get. But there are thoughtful people out there who keep raising this issue. It's amusing to me that when I first started in medicine, those within the medical profession who were most opposed to a universal government-directed healthcare system were those at the highest end of the pay spectrum, namely those in the surgical fields, surgical subspecialties, orthopedics. Today, those are the people who are most in favor, in many cases, of a universal healthcare system, because they see that that would be a much more efficient way for them to get reimbursed without all the complexities that we deal with today. And surgical boards, major surgical organizations have been leaders in coming out for universal healthcare, government-directed systems of medical care. Ironic, isn't it?
Yeah. So your feelings have pretty much stayed the same since you started practicing to now on the subject of socialized medicine, Medicare, and all that.
Well, you know, I mean, one's opinions modify over time. I mean, but the general sense that I have is that healthcare needs to be provided to everyone, and it shouldn't be something where people have to beg for, people have to feel like second-class citizens. We've got to figure out the way to do this so that it's part of the rights that people have. They have a right to health care and quality health care. Now, I'm not naive in that I think that, the destitute probably will never have as easy access to a heart transplant as the major CEO of General Motors. I understand that. and even in a system of universal health care, there probably will not be equality between those two examples to get that heart transplant. I understand that. And there may be mechanisms that develop whereby the government provides a certain floor of care, a certain guaranteed floor of care. And that guaranteed floor may not provide all of every single kind of technically complicated health care. I understand that. But for most primary care, that should be provided to all citizens.
When did HMOs first impact your practice?
Well, again, my activities were predominantly in the consultative area, as I mentioned earlier. But immediately when they appeared, we were aware of their presence. Being in an academic health setting, I was fortunate enough to have billing issues handled through a central office, although certainly we needed to gather and provide the appropriate information for those billers. As soon as they appeared, we became aware of their presence.
Would you like to comment on some of the positive or negative aspects of HMOs?
Well, I think HMOs have certainly called to the attention, or did originally call to the attention of the medical profession, the need for developing objective standards of care, the need for, within that type of thinking, for highlighting preventive aspects of medical care. And I don't think the word HMO necessarily means bad. The public will look at it that way. But HMOs have developed as of necessity because we have made the decision, at least up till now in this country, not to go to a universal health care system. So what developed was, among other mechanisms, HMOs. So one of their major goals, of course, is to provide high-quality, low-cost health care. Well, that works sometimes, but sometimes they are incompatible. Sometimes you cannot provide the highest of quality at the lowest of cost. You can try to provide high quality at an efficient cost, yes, but not necessarily at the lowest cost. Can you stop this while I take the phone?
How much did it cost for you to go to medical school?
I think it was in the $3,000–5,000 range per year. And you know what the cost of medical education today is, if you think about it, and you sort of, and it's very high, except in public medical schools, but certainly for the private medical schools. But if you multiply what inflation has been in over those years, it's probably just kept up with inflation. It probably hasn't increased enormously more than inflation or less than inflation.
How do you think school costs today influence the choices of young doctors when they graduate compared to school costs back then?
Influence their choice within medicine of a career, or,
yes,
or not of going, yeah, career within medicine.
Yeah.
Well, I can only try to answer that based on what they have told me, and I certainly had an extensive experience in talking with our residents when I was chair of medicine, residents in our medical residency program, and there's no question that is a major factor in choice of career, whether there are some people for which this is not a factor, and they will, regardless of whether they have debt or not, proceed upon the path that they want to do, and that's what they'll do, and my hat's off to them. There are others who have enormous debt and say that, you know, I want to go into a more lucrative field to get myself out of this situation, and there's nothing wrong with that at all. I mean, it's very logical and very appropriate, and people can make contributions to patient care in a variety of different mechanisms throughout medicine. I would say that there was I would say at least half of the residents I encountered, the economics of their medical education had a major impact on their subsequent subspecialty career choice.
How have doctors' salaries changed over the course of your practice?
Yeah. It's one thing I'd like to say about that is, although everyone feels that today, and probably correctly, doctors don't get paid in proportion to the rest of society as highly as they did, say, 20 years ago, they still are at the upper end of society in terms of getting paid. And I don't think that fact gets emphasized enough, and I don't think it should be forgotten. Doctors are still at the top 2 or so % of wage earners in this country. Now, I think they work very, very hard, and harder than virtually all other professions. And they, I believe, for the most part, are compensated appropriately. I do think that in many cases they are not paid as highly as they were 20 years ago, but I would not overemphasize the fact that I would not overemphasize that fact. I think they are still well compensated, even though many of them will moan that they're not paid enough. There probably isn't a billionaire out there in the big in the big world of high business who feels he should be paid even more.
Could you briefly comment on how malpractice insurance has changed over the years?
Well, that has increased markedly over the years. It goes in fits and starts. It goes, and depending on the specialty, but there are some specialties that suddenly zoom ahead and advance greatly, and then they plateau for a period of time, and then they zoom ahead again. But overall, the rates have certainly gone way up.
How did you learn the business of medicine? Did you ever learn it?
I guess that's an ongoing education. When I first started out, you learn it on your own. It was less complicated then. I used to, the patients I saw, I used to just gather the information myself, give it to my wife, and she'd send out the bills for the consultations that I did. It was sort of a very simple operation. Well, that's not possible today. I guess I learned about the business of medicine when I was chairman of medicine here at UMass through the School of Hard Knocks, and became much more sophisticated and experienced than I ever thought I would be, and had, of course, business managers to help me do that. So I learned a lot.
How's the ethnic background of your patients changed over the years?
The ethnic background, you
Yes.
said? I think it's changed substantially. I think within Worcester we've seen striking increase in the Hispanic population over the past, well, since the hospital opened here and the university hospital opened, and I think that's been a major population increase in Worcester. And I think those who have emigrated from Asia, Southeast Asia, Vietnamese, Cambodians, etc., Laotians, we have seen more and more of those patients. So I think it's become more diverse, and I think that reflects what's happened to America. We are a much more diverse society than when I grew up.
What do you like best about practicing in Worcester?
I think that the best part of Worcester has been its collegiality, and I think that was the most positive feature that I thought about physicians within Worcester, their collegiality. And I saw that for many years here at the University of Massachusetts Medical Center. I think as the years have gone by, perhaps a little bit of that has been sacrificed because of, the pressures of the business aspects of medicine, the economics. But I think that's happened everywhere, not just Worcester.
And lastly, what advice do you have for younger doctors, Dr. Blacklow?
I would say, do what you want to do. Don't let finances stand in the way. Don't let any pressures from any directions stand in your way. You should do what you want to do. Now, that being said, it should be a reasoned choice for what you want to do. You should think it through pretty carefully. But if there's something you want to do, and if there are roadblocks in the way, do your very best to try to remove those roadblocks and really go the direction you want to go. Don't just give up and say, well, I really wanted to be